Good evening, everyone. Welcome. Bienvenidos from all over the world joining us tonight for this virtual UHealth International Medical Series presentation, Innovations in Breast Cancer Management, featuring distinguished oncologists from UHealth, University of Miami Health System, and Sylvester Comprehensive Cancer Center. I am your moderator for this evening, health journalist Ileana Bravo. We are delighted to announce that Sylvester Comprehensive Cancer Center is the only cancer hospital that received the National Cancer Institute NCI designation in South Florida. Our experts are ready to take care of your patients in one of our 5 Florida facilities for in-person consultations, second opinion consultations, or via telemedicine from the comfort of their own homes. To refer a patient, we invite you to contact UHealth International at 305-243-9100. All the contact information is there on your screen. By email at uhealthinternational@med.miami.edu or by visiting uhealthinternational.com. So tonight we are privileged to hear from 4 experts who will share emerging breast cancer treatments and surgical innovations and how they can be used to help you provide the very best care for your patients. Our first special guest tonight is Dr. Felicia Knaul, who will present Breast Cancer in the Americas, Challenges and Opportunities. You will hear from her in a moment. But let me introduce our 3 expert oncologists from Sylvester Comprehensive Cancer Center, Dr. Elisa Krill-Jackson, who will present Breast Medical Oncology, What's Different at UHealth. Dr. Susan Kesmodel will present Optimizing Surgery for Breast Cancer. And Dr. Cristiane Takita will present Breast Cancer Radiotherapy Update. Now, during the presentation, we are going to poll you, the audience, from all over the world on topics relevant to each discussion. We ask that you participate tonight, although your responses will remain anonymous, but we encourage you to be a part of it. In addition, throughout the presentation, you have the opportunity to ask our panelists anonymous questions using the Q&A feature at the bottom of your Zoom screen. Take the time now to locate it. It has 2 little thought bubbles that say Q&A. Feel free to enter your questions as you think of them, and then we'll prepare them for the panelists at the end of the presentation. With that in mind, it is my pleasure and privilege to introduce our special guest this evening, Dr. Felicia Knaul. She is the director of the Institute for Advanced Study of the Americas, professor at the Miller School of Medicine, and member of Sylvester Comprehensive Cancer Center at the University of Miami. Dr. Knaul currently serves as chair of the Lancet Commission on Gender-Based Violence and Maltreatment of Young People, and previously chaired the Lancet Commission on Global Access to Palliative Care and Pain Relief. As a result of her breast cancer experience, in 2008, she founded Cáncer de Mama, Tómatelo a Pecho, a Mexican nonprofit agency that has promoted research, advocacy, and awareness and early detection of breast cancer since its inception, and has since expanded to promote women's health broadly. Dr. Knaul has produced approximately 250 academic and policy publications and serves on several philanthropic boards and received her MA and PhD in economics from Harvard University. Tonight, she will present Breast Cancer in the Americas, Challenges and Opportunities. Please join me in welcoming Dr. Knaul.
Liana, it is such a pleasure to be here with all of you, to be sharing a screen with so many who know what the University of Miami Health System can offer to Florida and to the Americas, and particularly to Latin America and the Caribbean, and country I call home, Mexico, where we now have offices, and I say hello to them. I know they're online, and thank them for all of the support that they've given for this event, because it really is about sharing information and sharing opportunities to help and support women. So with that, and proudly representing different parts of our university, I'll switch over and share the screen. Can you see it fine?
Yes, we can.
Lovely. So what I'm going to share with you quickly this evening, this afternoon, is around responding to the challenge of breast cancer in Latin America and the Caribbean. I want to thank Hector Ariola Ornelas, who worked with me on this presentation, as well as so many who work with us at the Institute for Advanced Study of the Americas and at our NGO, Tómatelo Pecho, in Mexico. I want to start where I always start these, which is with the personal experience. And you may or may not say I look like this anymore, but this is what I looked like in June of 2007. And I start here because I'm standing in front of a painting that's very, very important to this story and to our family. It was painted by my daughter, Hannah Sophia Frank Knaul, who was then 11. And she was painting sort of a Mom Botticelli. But the reason that I focus on this is for Hannah Sophia at that point in time, really a lot of the lifeblood that she saw in her mom came from my hair. And it was only a very few months later that I found myself in the throes of serious treatment protocol for an invasive stage 2 breast cancer. I had no history. I was diagnosed in my first baseline mammogram at age 41 in a small clinic in Cuernavaca, Morelos, Mexico, where all of you have your home, su casa. And at that point, I was the mother. I have 2 girls still, but at that point, as I said, Hannah Sophia was 11, and our little one, Marianita, was only 3. And I faced what most women face with that kind of a diagnosis and triple positive. A round of 16 rounds of chemotherapy, an unusual number of surgeries, and in my case, a full left side mastectomy with partial reconstruction. Now, that's only part of the story of what I want to share, though. It's really a story of a family who came together, the way that we learn to laugh at the disease over time, and very much the way that we approach this as a couple and as a family. You may recognize the man in this photo, some of you. He is the president of the University of Miami and my beloved husband, Dr. Julio Frank. Julio had just completed in 2007, 6 years at the helm of Mexico's Ministry of Health, the Secretary of Health. He founded the Seguro Popular, which was very soon thereafter. And for many years, fortunately not anymore with the change of government, but for many years, offer breast cancer treatment free of charge to all women of any level of income throughout the country. So he had just come out of this position leading a health system. He's certainly very studious of health systems. If he were here, he would say, though, that it's one thing to lead, it's one thing to learn, and it is another thing to live a disease that can take your beloved's life, your own life, and a disease that requires months, if not years, of treatment, that requires or has required until now so much movement and so much difficulty in access. For anyone, for any woman, even with the best access that one can get. And that's what we'll speak about, I'm sure, a little bit more. So the story I tell is a story that we learned together because, as you can see, I think chemo number 16 there. And for every one of those chemotherapies, he was in that bed with me and shared that process with me. So a lot of what I learned, we both learned, though, we learned from speaking to other patients. And that's what I'll share more of as we go through the evidence. And the patient I bring to you is Juanita. I met her a few years after my diagnosis, very advanced metastatic breast cancer. And I share her story. She passed shortly after this visit. I share this story because it's a story of a series of tremendously missed opportunities. You can't quite see there, but when I first met Juanita, I thought that Juanita actually had a mastectomy. And it turned out that she had not, but that the size of the lump that they had finally come to see in the secondary level hospital where they were trying to give her care was about the size of a large orange. And when I realized this, I said to myself, you know, my then 6-year-old Marianita could have done a better job at identifying this cancer early than our entire primary health care system. And so what had gone wrong? How had she had access to nurses, to physicians, to health promoters, and an extensive primary care network, and yet not managed to get there on time? And then How was she trying to get care at the secondary level hospital where they couldn't seem to connect to any of the oncologists, physicians, and centers of excellence that were really only about an hour and 15 minutes away from this Hospital de la Mujer in Jutepec, Morelos? And that's part of the story that we're going to share, I know, today. And it's part of why it's so important what we have to offer from UHealth, from our wonderful and amazing new NCI designated Sylvester Comprehensive Cancer Center. So let me turn now from this personal experience that we shared in a book in Spanish and in English, Beauty Without the Breast and Tómatelo a Pecho, and to some of the work that we did originally at Harvard University in 2011, 2012, and published in a book called Closing the Cancer Divide. And I'll make an early announcement that really no one knows yet, which is that we are very soon going to be launching a new Lancet Commission on cancer and health systems, and the secretariat will be at the University of Miami. So some of what you're going to see, we are going to be using going forward in a new Lancet Commission. A lot of what we did overall on global cancer, we learned from breast cancer. And we started with the idea of what are the myths versus the realities in our world. Typically, people think it's a disease of high-income countries, of older women, and it is of lower priority in places like Latin America than cervical cancer. And none of these are true. The majority of cases and deaths occur in low and middle-income countries. A very large proportion of cases and deaths occur in women who are premenopausal in these low and middle income countries, and there are more deaths and disability adjusted life years lost to breast cancer in almost every developing region from breast cancer than from cervical, except in the poorest countries of our world. Globally, breast cancer is the most common cancer among women. It is now the same in Latin America and the Caribbean. It's the second most common of all cancers in the world, fourth most common in our region. We're looking at close to 130,000 new cases a year and almost 50,000 deaths per year from this cancer. But it's sort of this piece of data that really wowed me when my team came together. We are now speaking about breast cancer as being the #1 leading cause of death among women aged 15 to 49 years in the Latin American and Caribbean region. It used to be #6 in 1990, so now the #1 cause overall. And we are again speaking in this case of younger women, premenopausal, many of them below the age of 40, and in a period of their lives when screening mammography is not the right answer. So keep that in mind as a message. The cancer transition in Latin America, looking over a period of about 40 years, shows a major increase in breast cancer and a leveling off of cervical cancer. But overall, we're seeing a positive percent change in mortality rates over time. So increasing, but beginning to increase at a decreasing rate. Our region is one of tremendous differences. Very high overall rates in Argentina and Uruguay, lower in Mexico, but with breast cancer coming up over cervical, same in Colombia, and a poor country like Haiti, one where there's still more women dying of cervical cancer than of breast, but breast coming up. I wanted to show you a longer time series of Mexico because it's part of the good news, the key part of the story I think we have to tell. I want you to look at the blue line, which is cervical cancer. And here we're looking from 1950 to 2019. What I want you to look at is how it peaked in the mid-'80s and how much that mortality rate has come down. Now, of course, breast is going up, but the reason I want you to focus on cervical is if we had been in a room, we wouldn't be on Zoom discussing this in the mid-'80s, no one would have believed that it was possible with opportunities for early detection and treatment to see this kind of a drop in mortality rates among cervical cancer. I'm talking a story of hope then. Now, compare what's going on in our region in terms of mortality rates to Canada or the US. And I could have thrown up Europe or Australia, as the other physicians know much better than I am sure. In all of these countries, we have seen a tremendous decline in the last 30 or 40 years in mortality rates. That's the green line going down in all of these countries. But again, in our region, we are seeing an increase in mortality rates basically across the board. But I've stuck in that dotted line for Mexico because we have some choices to make. We need to see whether or not that upward trajectory is going to continue to slope up or begin to slope down. Can it go parallel to what we're seeing in Canada or the United States? And what is required to make that happen? Is what happened in Canada and the US? It's awareness, earlier detection, and access to better treatment, because now we have the science to save so many lives. So what do we know when we compare Latin America, Mexico, and the United States in this case? The data for the United States are from the American Cancer Society. I think we all know them. It's pretty good news. The key is that we're seeing about 2/3 of women diagnosed in early stages of the disease, right? And an almost 100% 5-year survival rate. Now, all of the numbers are blue in the rest because, interestingly enough, for these data, and they're only partial, and they're certainly for comprehensive cancer centers in Latin America, but what we see is that when we reach women early enough, their survival rates are similar to high-income countries. They have access to good care, but we have much, much later detection. Less than 20% overall is what we're seeing across most countries in our region, early detected, and so able to get the most out of the treatment that's offered to them. Now, what is COVID-19 telling us? And this is the not good news. When we looked, and these are the data for Mexico, because we have these kind of disaggregated data, and you're comparing the number of women diagnosed, in this case for breast or cervical, or men in the case of prostate, in month by month in 2020 compared to 2019, and it's dropped. It doesn't mean that there is less breast, cervical, or prostate cancer. It just means that women and men are not being diagnosed. And the same for diabetes, and everything is the same except for anything that we think, any cause it's related to COVID. So this is a huge problem, because if we saw late detection before, we have a tsunami of even later detection that's going to come at us coming out of COVID-19. And we need to think, how can we convert this challenge into an opportunity to change the reality in this region? And so what I want us to think about, and I want to ask everyone who's going to listen to our panelists to see how they can offer this, is that entrenched problems require innovative solutions. And the chaos and challenge of COVID-19 can generate opportunities to close breast cancer divides. And I thought about 3 things. One is you can use telemedicine to harness primary and secondary levels of care for diagnosis and for treatment. 2, breast clinical exams. You don't always have to have mammograms when you have such late detection, but those can be done by nurses and by well-trained health promoters. And we have all sorts of new opportunities for training and exchange of knowledge and ideas in real time using things like Zoom that before were really quite rare. We saw it in St. Jude's for children's cancers, for example, over the last decade and a half, but it hasn't been generalized, and now it can be. So these are game-changing opportunities for being able to earlier detect, reduce the difficulties that women face in accessing diagnosis, and to offer them better care. I'm not going to go into this in detail, only to say that how much have things changed? Our NGO for about 15 years has been struggling to try to train promoters, nurses, and doctors and demonstrate that basic level health promoters can learn how to do good breast clinical exams and show that that education works. Well, now we have all sorts of opportunities to be able to innovate and train and to share information in real time in ways that we didn't have before. Go back to Juanita for a minute. This doesn't have to happen anymore. We can break down the silos that stopped those physicians, those general physicians in Jutepec from being able to speak to specialist physicians and oncologists, not only in Mexico City, but now in places like Miami, in places like our own Sylvester Comprehensive Cancer Center. That will be a game changer. So I close with this, which is the idea that closing the breast cancer divide is an achievable health equity and economic imperative. We believe that synergistic strategies combining advocacy and empowerment of women with universal health coverage platforms and harnessing all levels of care by permeating geographic boundaries and professional silos can now be developed, implemented, and evaluated. And that is the good news of what we've been suffering. I finally end with this. I always end with this. It's a picture, it's a moment that was so important because it's what taught me to think about what I sometimes call an economics of hope, to always be an optimist and an optimalist. I got septicemia in one of my last doses and I almost died. And when I left that morning, this little girl, I remember thinking, this time I might not come back. I knew how serious it was. It was different than any other moment in my cancer. I really knew. that there was a chance I was not going to see her again. And yet, thanks to access to amazing care, in this case in Mexico, this is a week later, we're in a butterfly farm in Canada, and her bald mom became the most popular lady on the block because all the butterflies came. So it just depends on how you look at things and how you can turn something into something very bad, into something that offers tremendous opportunities. And so I believe that our Comprehensive Cancer Center has so much to offer to make change. Thank you.
Thank you so much, Dr. Knaul, for this critically important overview of the current breast cancer challenges and opportunities in the Americas. It's truly eye-opening and sobering. And since you were so kind to share your personal story, I wonder on a personal level also, what would it have meant to you as a patient when you were diagnosed and for your family to have had this access to this kind of technology via Zoom from an NCI designated cancer center?
Oh, huge. I was very blessed because I was able to access care both in some of the best hospitals in Mexico and to have my care orchestrated and helped through by a leading breast oncologist, Dr. Julie Graylow, and be treated at the Seattle Cancer Care Alliance. But that said, Julio and I made a choice as a family that we would get the vast majority of my care in Mexico. We felt it was important to lead by example and show that you didn't have to run away from the country if you could in order to be able to get care. So again, the vast majority of my care was undertaken in Mexico. But it was hard. It was hard to go back and forth. It was hard to try to figure things out, to get all the testing shared. I remember my doctor in Mexico and Julie had to sit down at an ASCO meeting, which is the American Society of Oncology, clinical oncology meetings to try to talk through my case. And that was only going to happen once a year. Now this really can all change so that we can see that a patient anywhere can have access to the subspecialist care, the excellence that offered in places like Miami without having to travel. And now, what does that mean as a family? I remember a moment which was really, really hard, where my little ones were at home in Mexico, and they were very worried because I wasn't coming back. And the reason I wasn't coming back quickly enough was because we couldn't get some of the testing that I needed quickly enough. And they were so worried that I said to Julio, forget the testing. We're going to go back without going through that, and it'll be fine. And we'll go through with the mastectomy because it's better to be with the kids. It's better for them not to be afraid. And that's what I want to do. Had I not had to do all that traveling, had we been able to share things in different ways in real time, had I had that kind of access that now we can offer through our Sylvester Comprehensive Cancer Center to so many, I don't think I would have had to make that, really, really difficult choice. So I'm just proud and pleased. And what's hard is for me to say that I'll never stop asking our physicians and oncologists to help all of those patients in need, regardless of their ability to pay. And so I may be asking too much, but I'll continue to do so because I believe we can play a crucial role in changing the future in so many different ways.
Thank you again, Dr. Felicia Knaul, for your generosity of spirit and bringing your talent to us tonight. I'm sure your words have resonated deeply with this international audience and forum tonight. Thanks again for your time.
Thank you. And thanks to everyone who's doing this for so many.
Well, we are going to transition to our next speaker now, who is Dr. Elisa Krill-Jackson, breast cancer medical oncologist at Sylvester Comprehensive Cancer Center. She attended Yale University, where she majored in English and obtained her medical degree from the University of Michigan. She completed her internal medicine residency at the Brigham and Women's Hospital in Boston, then divided her hematology and oncology fellowship between Tufts University New England Medical Center and the University of Miami. After spending many years practicing hematology and oncology at Mount Sinai Hospital in Miami Beach, she moved her practice to the University of Miami, where she specializes in breast cancer. Throughout her career, she's been a local principal investigator in many national breast protocols from industry and national cooperative groups. Dr. Krill-Jackson's passion is to provide excellent care and to bring breast cancer education to Miami's diverse community. Please welcome Dr. Krill-Jackson. Unmute yourself there, Elisa.
There we go. Thank you, Eliana. It's a pleasure to be here. And I just want to echo Dr. Knaul because it is COVID-19 has clearly been an awful time for this world, but it has allowed us in medicine to be able to get our services and expertise to people who may not be able to come in, whether they're 20 miles away from us and it's just too long a drive, or in another country. I take care of a lot of people from the Bahamas and the Virgin Islands, and even Haiti, and we have been able to coordinate their care in their countries while they see me by telehealth. And it's been really remarkable for patients to be able to stay in their country, communicate with me. I can see them, face to face on a Zoom camera. And I think it leads to better care. They can stay home with their families and come when it's needed. So it's really been quite an eye opener. And I hope it's one of the things that we've learned from this COVID pandemic that will continue. So I'm going to talk about breast medical oncology at UHealth and what's different at UHealth. So this picture is one of our treatment rooms in our office in Aventura. Patients have this lovely little private space with a chair that can lay down. They have their own TV screen, and it's really a comfortable place if you have to be treated. So at UHealth, we have a full panel of clinical trials, both for neoadjuvant, adjuvant, and metastatic treatment. We're able to offer psychosocial services, including acupuncture, massage, exercise, and counseling for our patients. And most importantly for our patients, we have a very, very tight group of I think 9 medical oncologists, several radiation oncologists, 6 or 7 breast surgical oncologists that meet every single week, where we can discuss our patients with the most complex cases and come up with a consensus opinion for them. And I think that's really been one of the drivers of very good care for our patients who have complex medical illnesses. And my personal love is to help prevent hair loss in our patients undergoing chemotherapy. And we have freezers that can accommodate -30 gel caps to prevent hair loss. And almost all our offices also have hair loss machines that freeze the scalp during chemotherapy to help prevent hair loss, because I believe that patients feel better physically and emotionally if they look like themselves when they look in the mirror. And I've been recommending this to many patients, and I believe it really is helpful for them as they travel in their cancer journey. So I want to talk about our clinical trials at Sylvester, because I think this is a reason for patients to consult us to see if there's an appropriate clinical trial for them that may potentially improve their prognosis or make their journey easier. So the first trial that I'd like to talk about is Bristol Myers Squibb neoadjuvant ER-positive trial. So we know that ER-positive disease in the metastatic setting is not particularly sensitive to immune therapy, but we know in other illnesses and in triple-negative breast cancer, the earlier that you apply immune therapy, the more chance you have of responding. So this trial is looking at patients with node-positive or locally advanced estrogen-sensitive HER2-negative breast cancer and giving them standard chemotherapy with adriamycin, Cytoxan, and Taxol, and randomizing them to nivolumab, immune checkpoint inhibitor, versus placebo. Patients go on and have adjuvant nivolumab after their surgery, but this trial is looking to see if the addition of an immune checkpoint inhibitor will improve the pathologic complete response rate and hopefully the survival of our patients with locally advanced estrogen-sensitive breast cancer. Now, the next trial I want to talk about is an innovative trial called the COMPASS trial. So the COMPASS trial is actually looking at something different. It's looking at de-escalation of therapy. So we know that we're very, very successful in treating HER2 positive breast cancers, that we cure the vast majority of HER2 positive early stage breast cancers, sometimes with minimal chemotherapy, but sometimes with a lot more chemotherapy. And we know that we usually give 4 cycles of 2 chemotherapy drugs, 6 cycles of 2 chemotherapy drugs, 2 antibodies to patients, followed by an entire finishing a year of the antibodies. So this trial is looking at de-escalation. Can we just give 1 chemotherapy, just the taxane, and eliminate the carboplatin along with the 2 antibodies for just 4 cycles, 12 weeks, as opposed to 18 weeks? Will we get the same pathologic complete response rate or similar? Is de-escalation possible in these patients? So, as a group, we've decided that patients who do not have stage 3 disease, this is a very appropriate trial, although even stage 3 patients can go on this trial. We're also going to be opening a post-neoadjuvant for patients who do not achieve a pathologic complete response, giving the standard TDM1, but plus or minus tucatinib, a new drug, oral drug approved in the United States, which actually penetrates the brain and hopefully will prevent the problem that we have seen with relapse in the brain in HER2 positive disease. Next set of trials I want to talk about are adjuvant trials. So we know that patients who have a pathologic complete response to chemotherapy, either for triple negative disease or HER2 positive disease, have an excellent prognosis. However, the ones that do not, we want to be able to intervene afterwards and improve their prognosis. And we do know that we can do that with a medicine like TDM1 in HER2 positive disease, or with capecitabine in triple negative disease. But clearly we have not solved this problem entirely. So we actually have 2 post-neoadjuvant trials here at UHealth that are very exciting for patients with triple negative breast cancer that has not achieved a pathologic complete response to neoadjuvant chemotherapy. So the first trial is a national trial, SWOG 1418. And these are patients with triple negative breast cancer who have a residual of greater than 1 centimeter of disease in their breast, or nodes positive after their neoadjuvant chemotherapy. And these patients are randomized to either get pembrolizumab or just observation. So looking to see if adding immune therapy after neoadjuvant chemotherapy can improve their prognosis. Next trial is actually a very interesting trial called ACCRUE, which is actually a vaccine trial for any patient who's had triple negative breast cancer. So they can have had adjuvant therapy and surgery first for their triple negative breast cancer, or they can have had neoadjuvant chemotherapy with or without a pathologic complete response. And these patients are randomized 2-to-1 to vaccine plus GM-CSF with priming with oral cyclophosphamide, or placebo with GM-CSF after the priming. So very, very interesting trial for patients who are motivated to try to do something else to improve their prognosis with triple negative breast cancer. Now, our biggest problem, of course, is metastatic disease, and patients have a lot of options in breast cancer. However, at some point, the options are inadequate for the vast majority of our patients. So we're always looking for new ways to treat them. And we have several important trials that I'd like to highlight here at Sylvester. The first one is one where I'm the local PI, called the Bracelet trial. Now, this trial is for estrogen-sensitive breast cancer patients getting their first chemotherapy. So they cannot have been treated in the metastatic setting with any cytotoxic agent. So this is an interesting trial looking at a virus that is a non-pathogenic virus, meaning it really doesn't cause any physical illness, called palareorep. And palareorep, if you look here where my cursor is, at the graph here, Basically, when palareorep is added to Taxol in patients with metastatic breast cancer, we see a markedly improved overall survival in very early studies. So 17 months versus 10 months overall survival in metastatic breast cancer in this particular study. So it appears that palareorep may increase the immune system's response to a cancer. So this trial is actually a randomized trial where patients get either weekly Taxol, which is standard of care therapy for metastatic ER-positive breast cancer, or Taxol and the palareorep, or Taxol, the palareorep, and avelumab, an immune checkpoint inhibitor. So very, very interesting, innovative, exciting trial to know whether we can really affect patients' prognosis by revving up their immune system in an estrogen-positive breast cancer. Next trial I want to discuss is the Keylink trial. The Keylink trial is looking at triple-negative breast cancer getting their first treatments. And this trial gives carboplatin and gemcitabine plus pembrolizumab to everybody in the first-line setting. And after a response, the patients are then randomized to continue chemotherapy with the pembrolizumab or to get olaparib, a PARP inhibitor with the pembrolizumab. And theoretically, this should work very well because the PARP inhibitors actually are immune suppressive in themselves in that they increase PD-L1, which can decrease immune surveillance. But if you combine that with an immune checkpoint inhibitor to block that PD-L1 response, you may see increased response to the PARP inhibitors. So that's the theory behind this study, and really an excellent study for our patients with first-line triple-negative breast cancer. Now, a hormonal study that we have open for patients who are getting their first hormonal treatment for estrogen-sensitive breast cancer is an oral SERD study. So a SERD is a selective estrogen receptor degrader study. And the one drug approved that's a SERD is Faslodex. Faslodex has the disadvantage, or fulvestrant. Fulvestrant has the disadvantage of requiring 2 intramuscular injections a month for patients for treatment, which of course is difficult in terms of travel and is uncomfortable for patients. I have some patients who I have a lot of pain from it. I even have had patients who have stopped the drug because they find it so uncomfortable. So this is looking at an oral SERD plus palbociclib, which is standard first-line CDK4/6 inhibitor for metastatic estrogen-sensitive breast cancer. And it randomizes between letrozole or the oral SERD plus palbociclib. So everybody gets a placebo, the palbociclib, and then either the oral SERD or letrozole. So excellent study for patients. 2 more studies I want to highlight. This study is HER2CLIMB-2. So HER2CLIMB-2 is for patients with relapsed HER2 positive metastatic breast cancer after progression on a taxane and trastuzumab with or without brain metastases. So this is a trial that's looking to improve the prognosis of our underserved population with brain metastases. So this trial randomizes patients to TDM1, standard second-line therapy, or the combination of TDM1 plus tucatinib. So as we know, tucatinib is a recently approved drug that is highly effective against metastatic HER2 positive breast cancer and appears to be highly effective against brain metastases. So just looking at early data of this combination, what you can see here from the waterfall plot on the left is the combination of tucatinib and TDM1 is highly efficacious. The vast majority of patients have significant decrease in their disease when they take this combination. And what you can see here too, in terms of response rates, the standard tucatinib plus capecitabine and trastuzumab has a 42% response rate, and the tucatinib plus TDM1 has a very similar response rate but perhaps even a stronger effect on disease and decreased size of tumors. So the last trial I want to highlight is our NRG Firstline HER2 positive breast cancer. So I've talked a lot about immune therapy in triple negative disease now and in estrogen sensitive disease now. This trial is actually looking at HER2 positive disease where we're exceptionally successful in treating patients. But of course, most patients relapse. And what this is looking at is giving our standard combination of paclitaxel and trastuzumab plus or minus an immune checkpoint inhibitor. So again, another exciting way of looking for benefit of immune therapy in our patients. So with that, I am going to end my presentation and thank you. And if you have any questions, please put them in the question and answer area.
Thank you, Dr. Krill-Jackson. Yes, she indeed is going to be our question and answer moderator this evening for all of you internationally to ask your questions. And as I said at the beginning of the presentation, we are going to poll you in the audience to answer some important questions that contribute to our discussion. So here's our very first one of the evening. What is the rate of pathologic complete response to neoadjuvant chemotherapy in triple negative breast cancer? 20 to 30%? 30 to 40%, 50 to 60%, or 60 to 70%. We're going to give you some time now to tick the box that you think is the correct answer on your screen so that Dr. Krill-Jackson can tell us how you did. And I will remind you all to please enter your questions using the Q&A feature at the bottom of your Zoom screen. Take a look at it. I guess we can't do all of that, do the answers and the Q&A, because we're going to present them at the end of our presentation. So please put them in as soon as you can so that you can be included. Let's see what the results were of our survey. How did they do, Dr. Jackson, Dr. Krill-Jackson? How are those responses?
Unmute. Close. The actual response rate is only 30 to 40%. It's closer to 30% without carboplatin and closer to 40% with carboplatin. So we're not as successful without immune therapy. We're not as successful in triple negative disease. Now, the response rate is a bit higher with carboplatin or with immune checkpoint inhibitors, but not as successful as with HER2 positive disease.
Okay, all right. At least everyone participated. Thank you so much, Dr. Krill-Jackson. And we're going to move on to our next speaker, Dr. Susan Kesmodel, who's an associate professor of clinical surgery in the Division of Surgical Oncology at the University of Miami Miller School of Medicine. Dr. Kesmodel received her medical degree from the University of Pennsylvania Perelman School of Medicine and completed a residency in general surgery at the hospital of the University of Pennsylvania and a fellowship in surgical oncology at MD Anderson Cancer Center. Dr. Kesmodel specializes in the treatment of benign and malignant breast diseases and high-risk skin malignancies, including melanoma. Her clinical interests include prophylactic breast surgery for high-risk patients, oncoplastic breast surgery, and optimizing local regional treatment for patients with breast cancer. Her main research interest is in management of the axilla in both early stage and advanced breast cancer. Dr. Kesmodel is the director of breast surgical oncology and co-leader of the breast site disease group for the Sylvester Comprehensive Cancer Center and is responsible for organizing the clinical trials portfolio at the center, as well as serving as the chair for the Commission on Cancer there. She has written numerous articles on breast cancer management and outcomes and is a member of the Society of Surgical Oncology, American Society of Breast Surgeons, and the American College of Surgeons. She currently serves on the Publications Committee for the American Society of Breast Surgeons and the Melanoma Site Disease Group for the Society of Surgical Oncology. Dr. Kesmodel is also a member of the Breast Committee and the Breast Local Regional and Genetically Linked and Rare Tumors Subcommittees for NRG Oncology. Please help me in welcoming Dr. Kesmodel.
Thank you, Eliana. It's a pleasure to be here. And I want to thank everyone for joining us from so many countries. It's great to see so many people participating in this. And I want to echo what was said by Dr. Krill-Jackson and Dr. Knaul, that telemedicine has really opened the world to receiving outside consultations, and we're available to do that, particularly for patients who want a second opinion. And I also want to thank Dr. Knaul for sharing her experience, because I think that's the experience for many patients with breast cancer, and our goal is obviously to try and reduce the morbidity of the treatments that we administer and improve outcomes. So I'm going to share my screen. Can everybody see that? Yes, okay. So what I really wanted to focus on this evening are the things that we're doing at the University of Miami to try and reduce the morbidity of breast cancer surgery, and also to enhance the aesthetic outcomes. And I'm going to focus on three things this evening: reducing lymphedema, reducing axillary lymph node dissections, and then breast reconstruction. So as you know, lymphedema results from the multimodality therapy that we utilize for breast cancer, mainly surgery and radiation therapy, but chemotherapy also contributes. It usually occurs within the first 3 years of treatment, and it's likely highly underreported since patients are not followed specifically for this. It has a negative effect on quality of life, and it significantly increases healthcare costs, which can be a financial burden for patients. The likelihood of developing lymphedema depends on the extent of intervention in the axilla. The incidence with sentinel lymph node biopsy alone is only 4 to 8%. And in patients who undergo axillary lymph node dissection and receive radiation therapy, about 1/3 of those patients will develop lymphedema. And actually, there are some studies which show that that risk is even higher and may be greater than 50%. So we made a lot of progress in this area because we're doing primarily sentinel lymph node biopsy for early stage breast cancer. However, if you take the numbers in the US, we expect to see over 200,000 invasive breast cancers this year. And so that means that about 10,000 to 20,000 women and men will potentially be at risk for lymphedema, even if they only undergo sentinel lymph node biopsy. So I think this is an important thing that we need to focus on for our breast cancer patients. So we have a lot of expertise here at the University of Miami for management of lymphedema, and we are currently developing a comprehensive lymphedema center. This will include preoperative evaluation of patients who are having lymph node surgery, postoperative monitoring for lymphedema development and non-operative interventions, surgical techniques for lymphedema prevention, and then also advanced surgical techniques for patients with lymphedema. And I'm going to focus on some of the surgical techniques that we offer for lymphedema prevention and for management of patients who have lymphedema. So axillary reverse lymphatic mapping is a technique that we can utilize intraoperatively to identify and try and preserve arm lymphatics. It's something that we can do with either sentinel lymph node biopsy or axillary lymph node dissection. And the lymphatics are identified by injecting either blue dye or indocyanine green in the volar surface of the upper extremity. And then intraoperatively, we can track the lymphatics from the arm. Once the reverse lymphatic mapping is performed, there are several options. The best option would be to try and preserve the lymphatics. However, this is frequently not possible when we're doing a lymph node dissection. More advanced techniques that we can utilize are microvascular lymphatic anastomoses or simplified lymphatic anastomoses, which are known as Lympha and S-Lympha. Lympha is a microvascular surgical technique that can be performed at the time of lymph node dissection. And this is usually something that I will consider when I know that a patient requires a lymph node dissection. We currently have 2 trained microvascular surgeons who perform this technique. And on the right side of the screen, what you're seeing there, what you're seeing here is the blue lymphatics, which were draining from the arm, and this is the branch from the axillary vein to which they were anastomosed. And then we confirmed that the anastomosis is patent using indocyanine green and SPY technology. The one issue with lympha is that it requires microvascular surgery. So it's not a procedure that can be done at every hospital. And so recognizing the limitations of universal application of this technique, my colleague, Dr. Eli Avasar, described and developed another technique that he calls Simplified Lympha. It does not require microsurgery. It's the same concept. You inject blue dye in the upper extremity and track the lymphatics. And then under direct vision, we invaginate those lymphatics into a vein and secure them with absorbable sutures. And this is just what that procedure looks like. Basically, there's usually a small anterior branch of the axillary vein which can be preserved. We track the arm lymphatics with the blue dye, and then we put 2 non-absorbable sutures to invaginate the lymphatics into the vein. And the initial studies here show that this can decrease lymphedema rates by at least 10%. And these are just a couple examples from my own surgeries. This was a modified radical mastectomy that I performed, and you can see here is the injection and the blue lymphatic draining here. And you can see here that I've anastomosed this to a small vein branch. And here's a second one. Again, the blue lymphatic draining laterally. This is the thoracodorsal neurovascular bundle, and so this was a lateral anastomosis. One of the plastic surgeons that has joined our group, his clinical and research focus is actually on advanced lymphatic procedures, and he performs lymphovenous bypass and also vascularized lymph node transfers for patients who have lymphedema. And these are, his name is Kyle Zhu, and I thank him for loaning me these slides for this presentation. Here you can see an example of a lymphovenous bypass that he performed. Here's the blue lymphatic, anastomosed to a vein. Again, confirmation with SPY technology. And this is just the patient who had that lymphovenous bypass. This is 5 months after that procedure. She hadn't been able to put her wedding ring on for 5 years. And then this is 1 year after the lymphovenous bypass, and he also did some liposuction here, and you can see that the arm size is almost exactly the same. So these advanced techniques can be very useful for patients who have already developed lymphedema. So the second area that we're focusing on is trying to reduce axillary lymph node dissection, and obviously we're not the only institution focusing on this. And I primarily want to talk about the management of patients with positive lymph nodes. So the change in our treatment paradigms has really helped us to de-escalate surgery in the axilla. As you know, our old treatment paradigm was to do surgery first and then follow with adjuvant systemic therapy. However, many of our patients are getting neoadjuvant systemic therapy now and then having surgery. And this has allowed us to de-escalate surgery in the axilla. Just as neoadjuvant chemotherapy gives us important prognostic information and helps to guide the adjuvant treatment of patients, it also provides several potential surgical benefits. It certainly decreases the burden of disease in the breast, which allows us to increase breast conservation rates. And it also increases eligibility for more cosmetically favorable mastectomy procedures, nipple sparing and skin sparing procedures, and immediate breast reconstruction. And it also has the effect of decreasing burden of disease in the lymph nodes, which has allowed us to de-escalate axillary surgery in the axilla. And I'm sure that many people are familiar with the studies which have looked at de-escalation of axillary surgery in patients with positive lymph nodes after neoadjuvant therapy. And these have primarily been in patients with clinical N1 disease. So when we are considering de-escalation of surgery, we're primarily considering it in patients with clinical N1 disease and maybe select patients with clinical N2 disease. And this is currently our treatment approach for those patients. Patients with suspicious lymph nodes have axillary imaging. They then have a biopsy of the suspicious node and we place a clip. After neoadjuvant therapy, we do repeat imaging of the axilla, either with ultrasound or cross-sectional imaging. We then do a targeted axillary dissection approach, which is basically localizing the clipped lymph node and dual tracer sentinel lymph node biopsy. We utilize this approach because overall this has been shown to reduce the false negative rates. Our goal intraoperatively is to remove the clipped lymph node and identify at least 2 other sentinel lymph nodes. We do X-ray the lymph node intraoperatively to ensure that we got the clipped lymph node. And then we do intraoperative pathology on the clipped node and sentinel lymph nodes and determine management of the axilla at that time. So this approach has really helped us to de-escalate axillary surgery, reduce axillary lymph node dissection, particularly in patients with HER2 positive disease and triple negative breast cancer. We are certainly having more difficulty, as Dr. Krill-Jackson mentioned, in those patients with estrogen receptor positive cancers because they don't respond as well to chemotherapy. For patients, so as I mentioned, we're primarily doing this for patients with clinical N1 disease. For patients with advanced nodal disease, we're still performing axillary lymph node dissection. However, we are opening a prospective trial to evaluate targeted axillary dissection in patients with more advanced nodal disease. All patients in this trial will have the targeted ax dissection followed by an immediate axillary lymph node dissection so that we can determine the false negative rate of the procedure, the identification rate of the clipped lymph node, and the success rate of sentinel lymph node biopsy in this setting. So I just wanted to give one example of a patient in whom we were able to de-escalate axillary surgery using this approach. This is an 83-year-old woman who presented with an abnormal mammogram and palpable axillary adenopathy. Biopsy of the breast and axilla showed invasive ductal carcinoma, which was poorly differentiated and triple negative. This is the patient's mammogram, which shows that the primary tumor was actually relatively small, and these are the suspicious lymph nodes. And here's the pretreatment breast and axillary ultrasound showing the irregular hypoechoic mass in the breast, and this is the completely replaced axillary lymph node. This is the post-biopsy mammogram. I just wanted to show you this because this is the clip that we place in the lymph node. We actually use a relatively large clip because after the treatment, it's very, very hard to identify these lymph nodes on imaging. This is her pre-treatment breast MRI. So because the patient was 83 years old, we decided to start with 4 cycles of TC. And actually after that, breast imaging showed what appeared to be a complete clinical response. This was where the breast tumor was, and this was the enlarged lymph node with the clip in it. And I basically took her to surgery, and we were able to do a lumpectomy and a sentinel lymph node biopsy with retrieval of the clipped lymph node. And the patient had a pathologic complete response in the breast and axilla. So certainly this approach has allowed us to de-escalate surgery, which has the effect of also reducing lymphedema. So I also just wanted to briefly mention our stellar breast reconstruction group. As with most places, we offer all different kinds of reconstruction: oncoplastic breast surgery, implant-based reconstruction, and microsurgical flap reconstruction. We currently have 5 surgeons on staff with microvascular expertise. And I'm just going to show you a couple of results from these various breast reconstructions. So for some women, lumpectomy may be a challenge, particularly if there's a large area of ductal carcinoma in situ, or sometimes even a multifocal cancer. And so an oncoplastic reconstruction is a really nice option for these women where we need to excise a larger area of breast tissue. And basically the patient will simultaneously get a lumpectomy and a breast lift with a reduction to match on the other side. And this can be a really outstanding cosmetic result for patients. So, you know, while they're going through the treatment of breast cancer, at least we can do something to enhance the aesthetic results. As I mentioned, we are also doing implant-based reconstruction, and for many patients now, we're able to offer nipple preservation in the appropriate setting, particularly for patients with early-stage breast cancer or patients who have neoadjuvant systemic therapy, select cases. These two patients, we were able to do nipple-sparing mastectomy. The patient on the left had a two-stage reconstruction with a tissue expander to implant, and the patient on the right had a one-stage reconstruction direct to implant. And you can actually achieve very natural results with nipple preservation. And then finally, I also want to mention the expertise we have in microsurgical reconstruction. Again, for the appropriate patient, these cosmetic results can be outstanding. We can also offer flaps from other areas for patients who potentially can't use the lower abdomen or would prefer to use other sites. I should also mention that breast reconstruction is not for everybody. So we have many patients who opt to have a mastectomy without reconstruction. I think the most important thing for us is that we try and optimize the patient feeling whole at the end of their treatment. And so anything we can do to enhance that, we will try to do that. So I'm done, and I'd like to thank you for your attention, and I'll take any questions at the end.
Thank you very much, Dr. Kesmodel. And that transitions us right to our second poll question of the evening for our audience to answer as soon as it's on your screen. And that is, what is the likelihood of developing lymphedema with axillary lymph node dissection and radiation therapy? There are the choices on your screen: 5 to 10%, 10 to 15%, 20 to 25%, or 30 to 35%. And Dr. Kesmodel will comment as soon as we get the responses from the audience and see how our international forum will get this answer. And please remember, also, you have an opportunity to use the Q&A feature at the bottom of your Zoom screen to enter your questions for our panelists, who we have one more to go. And at the end of that presentation, we will tee those questions up for them. So how did they do?
Well, they did very well. So the likelihood of developing lymphedema, at least from the studies that are reported, is around, with lymph node dissection and radiation therapy, is around 30 to 35%. But as I mentioned, as we have some of these clinical trials, which are more closely monitoring lymphedema, we're actually finding that the rates are higher than that. So it may be as high as 50%, but so far the literature suggests 30 to 35%.
Okay, well, good. Everyone is aware and paying attention this evening. Thank you so much, Dr. Kesmodel. Our final speaker of the evening is Dr. Cristiane Takita, who's a professor and residency program director of the Department of Radiation Oncology at Sylvester Comprehensive Cancer Center, University of Miami. She obtained her medical degree at the University of São Paulo, Brazil, and a radiation oncology residency at the Mallinckrodt Institute of Radiology at Washington University in St. Louis. She joined the University of Miami Sylvester Comprehensive Cancer Center in 1999. She specializes in breast cancer radiotherapy, and her main research interests include evaluation of predictors of local regional recurrence, potential treatments to reduce radiation-induced toxicity, and healthcare disparities. Dr. Takita is the co-leader of the Breast Site Disease Group and the leader of the Breast Proton Therapy Group at University of Miami Sylvester Cancer Center. She is also the local principal investigator of many national breast protocols from NRG, Alliance, and CIC, including her own phase 1 clinical trial evaluating the safety and feasibility of preoperative stereotactic ablative breast radiotherapy, SABR, for selected early stage breast cancer. She's a member of several national committees, including NRG Local Regional Breast Subcommittee and NRG Rare Breast Tumor Subcommittee, American Board of Radiology, Radiation Oncology Oral Board Breast Section Committee, Astro CME MOC, and CHETI, the Committee of Health, Equity, Diversity, and Inclusion. Please welcome Dr. Takita.
I'm gonna share my slides. Can you see it? Okay.
Yes, we can.
Yes, I'm delighted to be here tonight to talk to you about updating radiation therapy for breast cancer. So the first question I want to ask is that what's the impact of breast radiation in breast cancer mortality? And if you look at this study from the Early Breast Cancer Trialist Group meta-analysis, which look into the effect of breast radiation of breast conserving surgery on the overall recurrence, local, regional, and distant metastasis and breast cancer mortality, you see on the first graph that after breast conserving surgery, the addition of radiation decreases at 10 years 16% any first recurrence, and which impact on the 15 years down the line a 4% decrease in breast cancer mortality. And this is, so then you can say that for every 4 recurrences avoided by radiation, 1 life is saved for a 4-to-1 benefit. So how can we increase the number of patients treated by radiotherapy? And of course, looking to decreasing the number of treatments. And that's why hypofractionation is being en vogue in breast cancer conservation therapy. So the rationale of hypofractionation in breast cancer is to shorten the treatment course, therefore improving access to care, decrease the cost to deliver care, as well as increasing dose per fraction without compromising the biologic effective dose. And as you can see on the table, these are 5 randomized trials comparing conventional doses of whole breast irradiation versus hypofractionation. And the local recurrence rate is quite similar between the 2 arms, with excellent and good cosmesis also comparable. And the classic study evaluating the hypofractionated whole breast radiation at 10 years results is the Canadian trial, which look into patients with T1, T2 disease, pathologically node negative after lumpectomy and node dissection, and randomized to standard 50 grazing 25 fractions versus 42.5 grazing 16 fractions. And as you can see on the graph, instance of local recurrence was the same with both arms, with excellent good cosmesis and late side effects also comparable. The UK START B hypofractionating trial for early stage breast cancer tried to answer the same question in about 2,000 patients. The fractionation used during randomization was 50 grazing 25 fractions compared to 40 grazing 15 delivered over 3 weeks. And as you can see on the graph, the instance of local regional recurrences is the same in both arms, but the better late side effects were seen for patients that receive hypofractionated treatment with lower rates of breast shrinkage, induration, and edema. The MD Anderson trial actually tried to look into the same question, but in younger patients, 40 or older, included DCIS also, and up to stage 2, as well as node positive patients for whom the recommendation was whole breast irradiation alone without regional node irradiation. And they used the same treatment schedule as the Canadian trial, except that a sequential boost was added. And the primary endpoint of the study was to assess acute and 6 months toxicity and quality of life indicators. And the results of the MD Anderson hypofractionated trial show that the physician report acute toxicity actually was better for hypofractionation with less any grade 2 or higher acute toxicity for the hypofractionated arm, as well as fatigue, breast pain, dermatitis, and hyperpigmentation. So what about ultra hypofractionated regimen in 5 fraction to the whole breast? So the FAST randomized phase 3 trial of a 5 fraction whole breast for early stage breast cancer looked into 900 patients from 18 UK centers in patients with pathologically T1, T2 node negative after breast conserving surgery. And the standard convention arm of 50 grays in 25 fractions over 5 weeks was compared to 2 experimental arms, 30 grays in 5 fractions once a week over 5 weeks, and 28.5 grays per 5 fraction once a week over 5 weeks. And the primary endpoint of this study was changing photographic breast appearance at 2 and 5 years. And the results of the FAST ultra hypofractionated breast trial at 10 years show that there was the 5-year overall change in photographic breast appearance, mild or marked change, was comparable for the 28.5 grays in 5 fractions arm to the conventional fractionation. The 30 grays in 5 fractions saw higher rates of mild to marked change. So at 10 years, there was no significant difference in normal tissue effect rates using 28.5 grays in 5 fractions compared to the standard arms, but it was higher for 30 grays in 5 fractions. So the conclusion was that the once weekly 5 fraction schedule of 28 grays was estimated to be radiobiologically equivalent to 50 grays in 5 fractions in terms of late side effects at 10 years follow-up. And this is a regimen that can be used for patients that are unable to counter radiation except for once weekly treatment, and also was used during the COVID pandemic on the worst time. What about ultra short hypofractionation trial for whole breast irradiation? So the fast forward trial, which is a phase 3 randomized non-inferiority trial comparing hypofractionated standard 40 grays in 15 fractions over 3 weeks and 2 experimental arms, 27 grays in 5 fractions over 1 week and 26 grays in 5 fractions over 1 week. And the primary endpoint is ipsilateral tumor relapse. So the fast forward trial results showing that the estimated 3-year cumulative incidence of any moderate or marked clinician-assessed late side effects in the breast or chest wall was similar of the 26 grays in 5 fractions with the standard conventional hypofractionation arm, but it was higher for the 27 grays in 5 fractions arm. The local recurrence rate was very low and similar for the 3 arms. So the authors concluded that the 26 grays in 5 fractions over 1 week was not inferior to the 40 grays in 15 fractions over 3 weeks in regard to local tumor control. And this regimen appeared to be safe in terms of normal tissue effects up to 5 years after breast conserving surgery, but we await the longer follow-up results of 10 years. So what about partial breast irradiation, which instead of treating the whole breast, we treat part of the breast with margins, which is a de-escalation of radiation volume and shorter treatment. So on this table, you see the randomized trials comparing whole breast irradiation versus partial breast external beam radiotherapy. The B39 trial and the RAPID trial from Canada use the 3D conformal radiotherapy partial breast arm for a dose of 38.5 grays in 10 fractions twice daily, 6 hours apart, delivered over a week. The import low trial, we use similar doses of the whole breast trial, but just to the partial breast, 40 grays in 15 fractions daily. University of Florence was using most modern technique of IMRT, intense modulated therapy, for a dose of 30 grays in 5 fractions once a day in non-consecutive days. And as you can see on the red table, is that the in-breast tumor recurrence comparing the two arms was very low and comparable. The cosmesis was on the 2 trials that did twice a day treatment over a week period. In the rapid trial, there was a worse cosmesis for the partial breast. On the 2 lower trials that used the daily fractionation, they had better results for cosmesis for patients that receive partial breast irradiation. And the hypothesis of the worst cosmesis on the twice-a-day treatment was that the normal tissues could not recover probably within the 6 hours apart regimen. There's also randomized trials comparing other techniques with whole breast irradiation like brachytherapy and intraoperative radiotherapy, showing similar results in terms of in-breast recurrence, except for the Elliott trial that had a higher rates of high-risk patients in the selection criteria. So nowadays, there's a trend to assess preoperative partial breast irradiation for early-stage breast cancer. And the advantage of that is because you have a better tumor delineation preoperative, a smaller treatment volume, and hopefully less toxicity, and allowing those escalation, as well as opportunity to assess tumor response to radiation. And these are some of the single institution published preoperative partial breast trials in early stage breast cancer in a highly selected group of T1 node-negative patients and a small sample size using different doses and techniques. And in a shorter 2 years follow-up, there was acceptable toxicity and cosmesis, and up to 1/3 in complete pathological response. Dr. Kesmodel and I have an open trial, a phase 1 study to evaluate safety and feasibility of preoperative stereotactic ablative breast radiotherapy, the SABRE trial, in select early stage breast cancer in patients 50 or older with T1 node-negative hormonal receptor positive disease. And we will assess multiparametric MRI, inflammatory immunologic assessment, biomarkers in blood, pre and post radiotherapy, and then patients will be treated with our real-time MRI guided system VRA and dose escalation in a modified 3-2-3 schedule, and the starting dose of 40 grays in 5 fractions in alternate days. The patient will receive a lumpectomy and a sentinel lymph node biopsy as a standard in about 6 to 8 weeks after radiotherapy, and post-operative assessment of pathological response as well as curative studies will be performed. And this trial is being supported by our cancer center. And this is one of our patients treated in the trial with a VRA MRI guided treatment. So what about to decrease lung and heart toxicity in patients that need regional nodal irradiation? And this is a seminar paper by Darby and colleagues that assessed the risk of ischemic heart disease in women after radiation for breast cancer. And the authors found that there is a 7.4% increase in major cardiac events per gray in mean heart dose. And that translates into the increasing rate of major cardiac events of approximately 16% increase per grade in the first 5 years, and then additional 16% per grade in the next 5 to 10 years. So proton therapy, due to the physical properties of proton therapy, can spare the entrance and exit dose compared to the photon therapy. And this is figure 2 illustrates very nicely proton therapy delivered at the depth to the tumor with a very low entrance and exit dose compared to the photon therapy in orange that you have a much higher entrance and exit dose. So I'm just going to discuss a little bit about patient selection for breast proton therapy. So the classic indications are bilateral breast cancer, cases that have re-radiation, or pectus excavatum. And this is a nice study showing in patients that have bilateral breast, chest wall regional node irradiation. On the left side, you see the proton treatment, and on the right, you see the same patients with a comparison photon IMRT VMAT, the most complex photon technique. And as you can see, the lower volume, which is purplish, treats pretty much both lungs and the heart in all cases of bilateral breast cancer. But with the proton therapy, there is spare of both lungs and heart in the 3 cases. Pectus excavatus, this is a congenital abnormality of the chest wall, and the heart is stuck right below the chest. And patients develop breast cancer, you cannot treat them properly without treating the heart with conventional treatment. So proton therapy is the standard of care for this kind of patients. Another selection criteria for breast proton therapy, if you want to decrease cardiac morbidity, is in women that have a known cardiac history. In younger patients that are likely to live long enough to experience long-term cardiac morbidity, patients with a left-sided breast cancer that have an unfavorable heart anatomy and are unable to perform breath hold technique, or treatment of internal mammary nodes and unfavorable breast anatomy. Some right-sided breast cancer with need for internal mammary nodes coverage have a very close treatment with the heart on the right side. Another patient select for breast proton therapy to decrease morbidity is if your patients are treated with photon plans that have an acceptable lung doses. So proton therapy does reduce the instance of radiation pneumonitis in the ipsilateral and contralateral lung. Also in the younger patients receiving proton therapy, we have a decrease in the lower dose range of radiotherapy, so that theoretically could decrease the risk of secondary malignancies. In patients that have high risk for lymphedema and shoulder stiffness, proton therapy can also avoid joint and shoulder without compromise axillary or regional nodal irradiation. And this is one of our patients that needed chest wall regional nodal radiotherapy after neoadjuvant chemotherapy with residual disease. And basically, you can see on the left, the lower volume dose is spreading through the lungs and heart with the photon therapy, and the IMRT treatment is sparing the heart and the lung. The REDCOM trial is the trial that will compare proton versus photon therapy 1-to-1 in a phase 3 trial in patients that will need treatment to breast, chest wall, and nodal irradiation, including internal mammary node. And the primary endpoint of this study will be the instance of major cardiac events. And it's expected that the patients with proton therapy will have a lower incidence of major cardiac events compared to photon therapy with similar oncologic outcomes. So in conclusion, hypofractionated whole breast irradiation is currently standard of care for breast cancer patients not requiring regional nodal irradiation, with comparable local control and better acute and late toxicity. Ultra hypofractionated whole breast irradiation of 5 fractions delivered once a week over 5 weeks is an alternative treatment for patients that are unable to come for daily treatments. Ultra short hypofractionated whole breast treatment regimens over 5 fractions in 1 week so far show excellent 5-year results, and we await the data for late side effects to mature. Partial breast irradiation is an option for patients with DCIS and low-risk early-stage breast cancer after breast-conserving surgery. There is ongoing research looking to optimal dose fractionation for delivery of external beam partial breast treatment, and preoperative partial breast irradiation are currently under investigation in many clinical trials, which will allow dose escalation and assessment of tumor response to radiotherapy. Breast cancer mortality has decreased over the last decade, but due to better treatment with increasing number of breast cancer survival. So decreasing radiation toxicity to the lungs, heart, and second malignancies should be our priority. And the RADCOM trial will assess if proton therapy will lead to less major cardiac events than phototherapy in the long-term follow-up. And this is our new proton facility, dual skin proton facility at Sylvester Cancer Center. And I'll invite you to come for visiting. And I thank you tonight for your attention.
Thank you so very much, Dr. Takita. And that moves us quickly to our final poll question, which we'll get in promptly so that I can toss it over to Dr. Krill-Jackson to start the Q&A. And that will come on your screen now, so please answer. The question is, hypofractionated whole breast irradiation is recommended, A, only for women 50 years of age and over, patients that have not received chemotherapy, or any patient that needs whole breast irradiation without regional nodes. Wait a few seconds to get our audience to answer this before we toss it to you, Lisa, so that we can get in as many as we can to answer the questions. Let's see if we get results here. Coming up. All right.
Excellent.
Was that correct?
We're paying attention. That's good.
That's always good. Well, thank you, Dr. Takita. And now Dr. Krill-Jackson, take it away.
All right. I'm going to take a few of the questions that were in the chat. The first one for Dr. Takita, a patient with HER2 positive breast cancer with axillary involvement who had 6 cycles of neoadjuvant chemotherapy, had a mastectomy, and 7 nodes were found to be negative for disease and had a pathologic complete response after neoadjuvant chemotherapy. Would you still recommend radiation to that patient, chest wall radiation?
Okay, current, the standard of care, even for patients that have low volume disease, so N1 clinically, prior to neoadjuvant chemotherapy, even with complete pathological response, is to deliver post-mastectomy radiation to chest wall and regional nodes. The answer to omit or the de-escalation of regional nodal radiotherapy for these patients with complete pathological response will be after the results of the NSABP B51 trial, which will answer the question for patients that have a node positive that becomes node negative after neoadjuvant chemotherapy. And that trial is not available, just closed. So it'll take few years for the results.
Okay, and one other question for Dr. Takita. Are there any studies showing cosmetic results of proton therapy with a breast prosthesis in place?
Yeah, that's a very good question. In terms of expected cosmetic results for proton versus photon is the same results. the proton patients might have slightly increase of acute side effects of the skin, but down the line, late side effects is expected to be the same in terms of skin toxicity, but much better improvement in the lung and the heart because of decrease of the volume treated for both organs.
All right, and one question for Dr. Kesmodel. Where did that question go? All right, some recently published studies have demonstrated a low rate of axillary recurrence in patients with clinical N2 disease that become N0 after neoadjuvant chemotherapy. Is it oncologically safe to omit an axillary node dissection in this clinical situation?
So I don't think we actually know the answer to that question yet. In the 3 larger trials that looked at de-escalation of axillary surgery in patients with node-positive disease, which was the ACOSOG Z1071 trial, the Sentina trial, and the SNFNAC trials, they primarily included patients with N1 disease. So I think there's very limited prospective information about patients with clinical N2 disease. And currently what we do is we would always discuss those patients in a multidisciplinary setting. Obviously, the patients with HER2 positive disease tend to have the best complete response rates. So that might be a patient that we would consider for de-escalation of therapy. But I think, again, it has to be in the context of a multi-D discussion, because if you miss disease, then you're also excluding that patient from adjuvant systemic therapy with Kadcyla, or for triple negative patients, Xeloda. So we certainly don't want to miss disease or leave disease behind in the axilla and potentially reduce the increased regional recurrence and reduced survival. So I'd say we don't know the oncologic safety of it, and it, again, would be a case-by-case basis for that type of patient.
All right, I think that is all our questions. Thank you very much. Ileana?
Thank you so much, Dr. Krill-Jackson. Couldn't have done it as well as you, I know for sure. Thank you all to our program has come to an end, but it was eye-opening and very important tonight to share with our international audience. So we thank all of you worldwide for tuning in. And we would like to thank our expert panelists for their expertise and for the generosity of their time tonight. We just want you to know at the University of Miami Health System that we appreciate your participation. We're ready to care for your patients. We invite you to visit uhealth.org to learn more about the topics covered tonight, or uhealthinternational.com to refer your patients for a virtual or in-person appointment with our experts. So hopefully you enjoy the webinar. Please complete the survey at the end and to give us feedback and to suggest other topics. But we wish you all a healthy and wonderful evening. Good night, all.